We're going to try to, we have this Scribe website, so we'll try to put these on there so you can kind of look at them. But you get the idea. Basically, you have a template, and you just kind of go through and ask them the questions. And the reason for that, these questions have been vetted so that they pick the right things that we need to know, as well as that we get credit for our billing, as well as medical legal. So obviously this is a knee, kind of blown up, so the ACL, you might have seen, so I had 2 ACL tears today. Some sport called soccer. Anyone here play soccer? And so that's pretty devastating. There's knees on, there's ligaments on the outside, so MCL, ACL, the LCL, and the PCL. So they're all little letters, but anterior, posterior, lateral, and front. Cruciate, anyone know what cruciate stands for? How about the cross? Cruciate? Cross. So it's crossing ligaments. Okay, sure, that's what that means. So anterior cruciate means it's attached on the front of the tibia and goes backwards. The ones on the outside, it's not uncommon for them to get injured. They're outside the joint, so they don't really swell, but you'll hear about all these things. A lot of times they're just called internal derangement. For someone like myself, as a sports guy, we need to know exactly sort of what's going on. So the anatomy's good. This is a test. You'll hear all these different kinds of tests. This is by far my most important test because I'm trying to see if this eddy is moving at all. So if it's a little bit loose, then I basically have to get them to relax, and then I'm trying to actually keep the thigh straight and then move it forward a little bit. So by a little bit, if you look at your fingernail, that's about 1 centimeter, which is about 10 millimeters. All it takes is a half of a fingernail, so 5 millimeters of looseness on one side. The other side is a full ACL tear. So ACL tears get missed all the time. But when you hear the Lockman test, that's how you spell it, and it's very, very common. The other one we see a lot is the McMurray's test. Basically, if their knee hurts, you bend it, you just gingerly kind of move it and see how much, because a lot of people can go all the way back onto their heels, with their buttocks, but if your meniscus is torn, it kind of hurts. And so there's different tests like that. One other term you'll hear is varus or valgus. So if I take the knee and push on it this way, that's a valgus stress to check the MCL, metatarsal ligament. And if I do it the other way, where I push it that way, that's varus. So that's a term that's kind of confusing that you'll hear a lot. And so laxity of valgus or varus is what you might hear. And then one other thing I just always want to bring up, there is something called the gamekeeper's thumb, similar kind of thing, where we'll do a valgus stress to the thumb. And I just want to give you this point because this was brought home to me when I was a young physician. So if you test like the joint, and initially it's kind of tight, all of a sudden you hear this pop, don't say oops, say there, boy, that thing was just about ready to go. Glad you came to see me, let's go get it fixed. So anyway, it's just kind of, thanks So like, you never say, ooh, that looks bad. Like, don't say that to patients because they're all like, looking at it. So let's see if this plays any better. So this is something I see every day is non-traumatic shoulder pain. So there is an arch under here on your shoulder. This is the acromion. Acromion means tip in Greek. And so there's actually an interesting ligament. I find it one of the most interesting ligaments. These are the ligaments. So there's tendons, bones, cartilage, all that kinds of things. So ligaments hold bone to bone. Tendons hold muscle to bone. So usually, like if you have an anterior talofibular ligament of the ankle, that's where you sprain your ankle. It goes from the talus to the fibula. Anterior talofibular ligaments, which just tells you exactly what it does. Interestingly, the C8 ligament, coracoacromial ligament, goes from the coracoid to the acromion. So it's actually a bump on a bone to a bump on the same bone. And it makes an arch. So you have the acromion, which makes an arch, and that makes an arch. And then these two things have to run underneath it. Interestingly, this bone, if you cut this, it doesn't go anywhere. The bone's there. It's all part of the scapula and stuff. So, but it can be part of the impingement process. And so, bottom line is, it's something that we a lot of times will release, and the acromion is sort of too tight, it gets jammed in there. So we'll do a acromioplasty. And then the other thing you want to know about is that there's a joint and a space. So you look at here, this is the shoulder joint, whereas this is a subacromial space, sub meaning under. And two things live in the bursa and then the tendon. And the tendon can get impinged or pinched on, and soft tendon between the two hard bones, tendon loses. You can get tendinitis. And what's worse than tendinitis? Lepidinitis? That was mine. Actually, you get a partial tear or a full tear. So you may hear about all that stuff. So let's see if this plays at all. Otherwise, I won't let you push yourself through this if you can't hear it. So pain in the right shoulder, 2 or 3 days. So 6 or 7 at rest, the pain scale. 9 with activity. So sudden pain. So I won't put you through all this, but that's kind of the stuff that we kind of want you to do. You'll just kind of go through that litany. So on the testing, we'll look at there's different tests for the shoulder. The nearest test is a forward subacromial. So a lot of people have bad posture, like half-heel. You know, it's just like you guys are like this all the time. And so it really jams in that subacromial arch, and then that stuff that kind of jams. And a lot of us do push-ups, and not as many do extension stuff. So it's very common to be overbuilt like this. And so when you come up on that, your acromial is like this. The humerus, there's nothing funny about it. You kind of jam into that. So if I can get their shoulders down and back, I can kind of open it up. So the test I would do is a forward test called the nearest test. And then there's the Hawkins Kennedy test, which is you kind of come up and then you, because there's a greater tuberosity on the humerus, you'll actually flip it this way and kind of bring it across, and that all hurts too. So these are all what's called impingement, which used to be called bursitis, tendonitis, we lump it all together. And the supraspinatus testing is also called the empty beer can test, which none of the fraternities know about. They don't do it this way. They do it this way, sorry. But you actually, rotator cuff is all posterior muscles, so they'll bring it out to 45 degrees, turn your thumb down, and it's this test. So if it hurts when you test it, that's basically tendinitis or tendinosis, long-term tendinitis. But if you do this and they can't keep it up, it literally drops, then they have a full rotator cuff tear. So those are the little tests that they'll be doing on. So diabetes, we'll kind of go through, so I apologize. We'll have to work on this maybe next time. The big thing on diabetes is number one cause of amputation of the foot, blindness, kidney failure, and so we're kind of excited because, especially with the ketogenic diet, with the prolonged fasting, you basically just reverse at least 60% of it, what the study showed in March, so we're very excited with that. So you'll hear about something called the monofilament test. So So every time they come in, we have to check, do they have good sensation to their feet. So this is called the monofilament test. It's basically a fishing wire that we push on their feet and ask them if they feel it. And the way you would document that is you do 4 different places. You do the big toe, kind of the ball of the foot, and then 2 more places. So it's 4 out of 4 on the right, 2 out of 4 on the left, and that'll give you the idea for the diabetics. There's a urine analysis, which is just regular urine for like the infections, but then there's the microalbumin urine test. So when, as I said, the diabetes leads up the kidneys, one of the first signs that you're starting to have kidney disease is you can't hold on to albumin, which is like a very important protein, and you start to spill it out in micro amounts. That's what I call microalbumin. So they should be tested for microalbumin once a year. So that is something else that you'll see. And then they should get, and again, it has to be in each calendar year. So that's another thing that we get on, is they should have a dilated retinal exam to look and see, do they have diabetic retinopathy. So those are kind of the things that you're going to be asking about, and you may need to be documented. And then hemoglobin A1C, which is, I don't know if I told you guys this story, but I tell you what, I had hemoglobin on the board. So it turns out, I'm kind of a dummy, I don't know a lot of things, and so when I'm a third-year student, after the first 2 years of med school, then you go in the wards, and the wards are like a scary place where you're actually taking care of patients, not just filling in bubbles on a scantron. And so my first patient, bottom line is I had a professor, like an attending, and I didn't really know who she was. There's no internet those days. She literally looked like a refrigerator with moving eyebrows, and she's just this big lady. And it was Helen Rainey, and she discovered something called hemoglobin A1C. I never knew it would be a thing. And so it just turned out I was very fortunate to have like this amazing woman. So she was one of the first powerful women in medicine, super bright. She was a hematologist. We got along fabulously, except she didn't like my little humor. But I was able to like survive, and it worked out really well. So I was sort of homage to her, because if you get a chance, she died at like age 99. So she was quite good. I was mouthing off about some. She goes, "Oh, you think you know something?" But I stay up all night and I talk a lot. Anyway, if I don't sleep at night, I really talk a lot. She's like, "Well, go up to the board and draw the hemoglobin molecule. Label the histidine." Oh, it's histidine. And then break it down. So if you get hit, it's black and blue, right? Well, each one of those colors has a name. Bilirubin, biliverdin, and eventually it's bilirubin is when kids get jaundice sometimes. So that's basically a breakdown of it. So anyway, she wouldn't let me off until I tried to draw every molecule. Still nightmares to this day. But anyway, getting back to hemoglobin A1C. So that is a good way to know how the diabetics have been doing over the last 3 months. So if you're diabetic and there's too much blood sugar, you get what's called glycosylated hemoglobin, and your hemoglobin A1C will go up. So sometimes people tune up for the doctors, like, "Oh, I'm going to go to the doctor today, let me take my insulin today. I haven't taken it in the last month. Let me take it today." They come in and blood sugar is supposed to be 100, and they're like 100. Wow, but they just look horrible, and you know that they're lying to you. And so you do a hemoglobin A1C every 3 months, and if it's below 5.7, that's normal. Above 6.5, you're considered diabetic. So I have a lot of people, like this lady today, she's 6.7. Like, "You're diabetic." "I'm not diabetic." "You are diabetic." And I circle on them, and I give her a sad emoji. Everybody doesn't. And then I say, "Don't die on my watch, because you're going to do a bad job." It's all about me. So let's, maybe mix in a salad, push away. You have a question?
Yeah, I was just curious, is this A1C related at all to the sleep apnea that a lot of diabetics develop, or is that not?
Not, they get a lot of stuff. It's not. They usually, if they're having bad diabetes, usually, especially type 2 diabetes, they're overweight, and that's usually what causes that. So this is sort of related to it, but it's not necessarily a strict cause.
No.
So anyway, you're going to hear about the hemoglobin A1C, and that's a big deal to know. And the cutoff there, so you know, is 9. We got to try to get their hemoglobin A1C under 9, or we get like a slap on the wrist. For me, I'm very excited. This is sort of our research. If any of you guys want to help with that, we're really not treating diabetics; we're converting them, and we prove it by their A1Cs going down. So sinusitis, almost out of time, so I won't go through that. But this is something to kind of look at. the thing on sinusitis is they'll have curdling nasal drainage. They don't have snot, they have curdling. Okay? And it's the tympanic membranes of the eardrum. And serous otitis media is on the inside of the eardrum. One last couple of things to talk about. So you're going to hear about expander codes. So that's that thing we were talking about where you just write a couple of things, a couple of sentences, and it'll kind of do that. So for example, the one that I use a lot of is .ttp. So instead of saying, writing tenderness to palpation, with range of motion, neurovascularly intact, I'll just say, okay, shoulder.ttp, and that gives me a reasonable start to something. So this is the kind of stuff that you'll see. So templates are like finished note, but expander codes, and you'll learn literally hundreds of them that you can use as a shortcut to expand your note. So in summary, my big deal is Occam's razor. Anyone know Occam? Heard that a little bit? Yeah. So the big deal, I like this whole idea that it's sort of tragedy to do more with what can be done with less. So Occam, I forget where he was in England, but his whole theory was it's better to sort of do less, like less is more, like it's better to. So my goal for you guys is to get so that you keep working on your notes so that it says everything you needed to read, but not more. So that people don't have to read through tons and tons of notes, because basically that's where mistakes happen. It's all going back to patient care. So Occam's razor is very good. I think in summary, you can look at the Medical Scribe website. Obviously, we're going to try to get better at giving you guys actual tools to do this. What I'm trying to do in this course is just going to give you an overview of kind of what to expect, and then that's where, when you're doing your internships, that you'll actually get them rubber meet the road. And it may take you, several hours to do your first note. Understand, I see about 40 patients a day, so I've got to rock and roll, and I need people's help to get the majority down. It's my responsibility. I got to read it over, and I'll fix it. My goal is to be a publisher, not an editor, and so we kind of work with it. And for you guys, I personally think you should. I know they tell you not to, but I would try to diagnose the patient. Like, okay, they give me all this. What do you think they have? And talk to your provider. I mean, I love it with pre-meds because, what are you thinking? What's on your, we call it differential diagnosis. And I would encourage you every day to find one patient that you can, like, okay, I see this diabetic. Okay, every time I think about diabetes, I think about Mrs. Smith. You don't have to think about diabetes, you just think about Mrs. Smith and all the stuff you do. And the goal is to try to find one patient for every disease. And then on the flip side, you kind of want to have diseases when someone asks you questions as med students. This is my biggest secret. And this saved Tanner one time. So if someone asks you, what do you think it is? Like if someone asks you, like say the guy's talking like, hey, what do you think this patient has? And you have no idea what do you think this patient has. That's when you pull out this disease called Macchiafafa-Bignami syndrome. So it just sounds good. It's very rare. It happens, it's a corpus callosum degeneration of the brain that occurs typically in Italians drinking red wine under a bridge. But everybody could be alcoholic. And so it's always in the differentials. And it turns out, for about, I've been teaching for 30 years, that several times it's been like a rare case that's been in like what's called grand rounds. And the med student like knew it, and they thought he was like an idiot savant because no one knew about it. And that's the same with what Tanner did. They had this patient who's caught under a bridge, like doing something. What else do you think you could have? And, he's Korsakoff and all these other sort of basic ones. And then he goes, maybe that Macchiafafa-Bignami. Like even the attendant's like, really? They have to Google it and stuff. So anyway, I'm just saying, it's fun both ways. I just think try to have fun in, not as soon as you can. I mean, you don't want a lot of big words. It is like taking a drink from a fire hose. But I think, especially with medical scribing, but if you guys take it to the next level, where you try to be proactive and help the provider, like, what do you need, what can I do? They're going to like you, and then they're going to be able to teach. Because if you lessen their load, then they'll have time to teach. But if you're literally a pain in the ass and you're like lazy and not doing stuff, then it's not going to go well. But you need to become part of the team. A scribe is very important, as I think one of the folks told you. Like, they will love you. Like, they will like bless you. They will honor you. Like, because if you don't show up, they will cry. Because you have to do it all. And there's just no way, given all the metrics and stuff we have to do it, I think, without a team. So you guys will be very valuable parts of the team. It's a ton to learn. Once you learn it, you'll learn it the rest of your life. If you can learn, get the teamwork down, get the technology, and then build trust, then that's very good. I can't overemphasize being very compulsive and understand you're going to make mistakes. You're unfortunately going to hurt people. It's not your intention, but that's going to happen. And you just got to learn by every mistake and not beat yourself up too much for it. So I'll give you guys a little kudos for sitting through all of this. We're going to try to keep working on our technology, and then we'll see you back next week. And then, Logan, did you need to tell them anything about signing up?
No, I think we might have purchased them today, if not, it'll be tomorrow morning. And then they said it'd be like a couple days to process everybody's accounts. You're each gonna have to self-register. I'll give you a code to access that. They're gonna take down your information, like your name and email, and then you're gonna be prompted to pay something with a credit card. It's gonna charge you $0, 0 cents, like I said in the email, but that's just so they have your card on information, because you guys are in charge of your annual renewal fees. So next year, you'll have that card on file, so it'll just recycle instead of the city having to organize the funds for that. So.
And then you have to decide if you even need to do that next year, because the certification is good, but if you're already like in med school or whatever, you need to do this. And then on the internships, the big deal we're going to be working on is sort of how to help you guys get your internships at various places. And the big thing on that is I would start to do a resume now, like we call it a CV. What does CV stand for? Curriculum vitae. What does that stand for? It's your scholarly life. So vitae is life. Curricula is so curriculum vitae you'll hear. So we doctors don't have CV. We don't have resumes. We'll get a CV. So that's what you kind of want to get from whoever your doc is. Hey, you gotta get your CV, and then you can kind of know all this stuff that they like brag about it and bring it up. But I always like to know pedigrees, like high school, college, med school, residency, fellowship. It just gives me something to talk about. But so you should start working on your CV now, like where you go to high school, any honors you did, which I'm sure you guys got a bunch, what college or whatever you're going to now, what are your activities, and then we'll do that with a cover letter, and then that's wherever you want to go. Will help you to get your internship, so you get that done. And then the other is, let us know. I gave you. Did you give them? Logan, did you give them the evaluation?
Yeah, it should be in the back. I'm not sure if everybody picked it up.
So if you guys can help me, obviously this is our second year doing this, kind of monitoring through this. There's not a lot of courses around. They charge $1,000, $7,000. Do it free to help you guys get going. I know it still costs to get started.